Thank you for joining us. This is our monthly podcast that we do on mental health topics. We talk about kind of wellness, mental health, things that are hopefully important to our community, to our audience, and we try to demystify kind of what kind of help people can get, what services are available in our community, things like that. So I know you've been quite successful in running a primary care clinic. It's direct primary care, right? So maybe can you say a couple words about the work that you're doing, and then I know we talked about some questions, but we're going to get into about mental health in particular in your setting. So just can you give the audience kind of just a quick? I know you've been kind of working in our community for a long time. Just a quick intro to some of the work that you're doing.
Yeah, I'm a family medicine doctor, Dr. Paul Thomas. I started a practice called Plum Health. We are a direct primary care service. Um, what that means is that patients enroll with us either as an individual or through their businesses, and we deliver primary care services directly to our patients. So, um, what that looks like in reality is same day and next day visits are guaranteed. We usually meet with 1 hour with our patients for 1 hour for the first visits. Follow-up visits can be 30 minutes or they can be 1 hour, depending on the complexity of your situation, the severity of your symptoms, and many other factors, social, cultural, etc. And we also save our patients 50 to 90% on medications, lab work, and imaging services. And we can take care of about 90% of any individual's healthcare needs in a given year in our Plum Health Clinic, or virtually, or through text
Sure,
message, or
for sure.
any
That makes
sort of asynchronous communication.
For sure. That makes sense. No, that's really great. And you work with individuals and companies like to offer services to their employees.
That's correct. Because when a company has, let's say, over 200 employees, or if you're more aggressive, over 100 employees, that company should be self-funded. So they basically keep a pool of money and then they pay out the claims directly to the doctor or the hospital when their employees get sick or go to the hospital. That way they can be in control of their healthcare costs. If those companies are smart and forward thinking, they'll engage with a direct primary care service because they know that we can reduce their ER utilization for their employees by about 40%, saving them $2,000 per ER visit. And we can reduce their urgent care utilization by 75%, saving them about $300 per urgent care visit. And we can reduce their need for telemedicine completely, saving them about $110 or $120 per telemed visit, right? So those savings add up
Yeah.
week over week, month over month, year over year to become huge savings. We usually save employer groups about $1,700 per year per employee. So if you have 100 employees, um, you can start to do the math how we might save a company $170,000 a year just on their
Sure.
healthcare costs.
Sure. Well, I mean, it's a really great service, and I know you do a lot of work. You do a lot of presentations that kind of talk about the work that you do. And since you spend so much time with the person or maybe their family members, right? I wonder how do questions about mental health or emotional health come up? I think that's one of the unique, you have a kind of a unique perspective. Usually when you go to see a primary care doctor, like I have a really good physician I work with. I like him a lot. He's part of the Corewell kind of ecosystem, but I see him once a year. We check in, it's really helpful, but not due to lack of time, but maybe we just don't spend that much time together. He might not be necessarily the first person I would think of to say, I'm struggling with, anxiety or depression or something that's affecting my life, right? I mean, I wouldn't not say that to him, but we don't see each other that much. But I think you have, through your model, you're, I'm guessing you kind of know the patient a little bit better, or maybe you spend a little bit more time with them. Can you give the audience kind of a sense of how do these questions come up? How do the conversations around mental health happen in like a direct primary care setting?
Yeah, let's just take a 10,000-foot view. There are some counties in Michigan where there's only one psychiatrist for every 250,000 to 1 million residents. There are some counties in Michigan with no psychiatrists. In Detroit, in Wayne County, our ratio is a little bit better, but there are too few psychiatrists to see the population in Michigan, period, end of story.
For sure.
So what the other 10,000 foot view is that we're family medicine specialists. We specialize in family medicine, and we have this really broad and sometimes deep training in different areas. One of those areas is psychiatric medicine.
Yeah.
We can handle depression, anxiety, ADHD, bipolar disorder, and PTSD, insomnia, sleep dysfunction, so many other conditions. And when people feel depressed, they may not know they're depressed, and they may think, well, I need to see a psychiatrist.
Sure.
We talked to an employee of a group who was waiting 9 months to see a psychiatrist in Oakland County. Nine
Sure.
months.
Yeah.
The average wait time is maybe 8 weeks in Metro Detroit, maybe 60 days or 90 days. But still, if you were to engage with a direct primary care doctor like myself, I could see you today or tomorrow, and I can start you on an antidepressant today, and you'd be feeling better in 30 days. And you'd still have, another 30 days or 90 days before you actually see a psych. So what I'm trying to say is that we have a lot of strength in terms of managing depression and anxiety.
Hmm.
Some people come to us thinking that they have low testosterone or thinking that they have hypothyroidism, right? My thyroid must be off. I'm feeling fatigued.
Yeah.
Okay, let's do a depression screening. It's called the Beck's Depression Inventory. Okay, it looks like you're scoring high. Let's do a Hamilton Anxiety Scale. Let's check your blood panels and make sure your thyroid hormone's normal. And when we have all of that information back 24 hours after the visit, we can then start the medication. Sertraline, 50 milligrams, and that's 3 cents per pill, right? So for a 30-day supply, you're paying 90 cents to manage a depression issue that was crippling you or having you not perform at your best for the last 6 months or a year. And that's a powerful transformation that can happen within the walls of a direct primary care office.
Right. So the turnaround time is much quicker, and the person doesn't have to sort of they could have a better idea of what's going on. They're not sort of struggling thinking something's off, but I don't know what it is. Let me kind of look up WebMD or something, kind of look it up on my own. They're more, not that there's nothing wrong with online resources, but
Yeah,
they
nothing
have
wrong with that.
a clinician they could directly discuss their challenges with, who could do like a thorough assessment.
Yes, and many people go to their annual physical with their insurance-based primary care doctor, and because they only have 10 or 15 minutes with that doctor, they get this superficial or cursory once over, and these things don't come up in that compressed time frame. But when you have an hour with the doctor, there's some time for the conversation to breathe. There's other questions that can be asked. One of my favorite things to say at the end of an appointment is, is there anything on your mind that we didn't discuss today? And then pause and wait for them to come up with something because people have issues with um, feeling depressed, feeling anxious, not sleeping well that aren't top of mind, but may come to them when they have more time to talk it over with a doctor that they trust.
Sure, that makes sense. And but the interventions are typically, I guess they start with medication, right? What about, I don't know, therapy or kind of those kind of interventions? Is that, I guess some primary care offices will have, sometimes they'll have a clinician on staff who does therapy. How do you see that? What role do you see for direct primary care in terms of maybe like an ongoing treatment for some mental health, emotional health challenges?
Sure. As we all know, mental health is multifactorial, and most doctors, most clinicians know that the gold standard of treating depression and anxiety is the marriage of medication plus cognitive behavioral therapy or CBT. So I can give my patients a brief rundown on what cognitive behavioral therapy is in 10 or 15 minutes and we can reinforce that over a few different visits, redirecting external stimuli into positive thoughts rather than making them negatively internalized. But we also know that there are specialists who engage in this work. So we have a long list of sometimes free options, sometimes really reduced cash pay options, and also insurance-based options where we direct our patients. Look, I'm starting you on an antidepressant today or an anti-anxiety medication. Here's a list of psychologists or behavioral health professionals that you should reach out to for additional therapy and counseling.
And do you find that people, what's your sense of the follow-up? Like, therapy, talking about mental health is difficult with could be one's primary care physician, but in general, I think sort of like we sometimes refer to as compliance, but the follow through of following up on therapy or sticking with the process or really kind of making use of those resources sometimes I think can be hard because it can be hard to do. You have to sort of confront things that might be not easy. What do you see in your work? I mean, again, I think you might have a somewhat closer relationship with the patient. You may know them a little bit more, so you might have more sort of positive influence on their ability or willingness to follow up on those kind of services?
Yeah, that's right. So I guess first off, when we make a diagnosis of depression or anxiety or PTSD, that's not the end of it. That's the beginning of the journey, right? Or part of an ongoing trusting relationship. And as we get to know our patient better, we have monthly meetings with them. Once we make a diagnosis of depression, we're going to have monthly meetings with that patient. And every time we meet, I print off our Beck's depression inventory and I have our patient take the test either on a piece of paper or we actually have a test you can take online that goes right into their EMR. So
Yeah.
we have them fill it out on paper, maybe if they're older, prefer paper. Then we upload it in their chart. And we want to see the stated goal, obviously, in talking to the patient, is like your Beck's depression inventory is coming in at 25. So that's moderate depression. You should be on a medication. And so as we meet, I would expect that after a month, you might fall in the 16 or 18 or 20 range, or maybe lower. And then after another month, maybe you're in the 12, 14, 16 range. And maybe after another month, you're in the 10 or 12 range, right? Um, I don't expect you to get to zero because most people walking around are at 10 or 11. Um, these ups and downs are considered normal. And so as I get to know my patient better, it could be that medication alone gets the job done. It could be that medication more dedication to better sleep habits, like sleeping more, getting the phone out of the bedroom, not watching TV for hours on end in bed, no Netflix binges in bed, those sort of things, or exercising every day, or eating healthier meals, or being more intentional about engaging with a social group. All those things have positive benefits on our mental and emotional health. Or, in Michigan, we get the seasonal affective disorder. It's harder to be outside in January, February, March, or December,
Right.
January, February. And now that it's May, we're recording this in late May. So, it's a perfect time to get out on the Riverwalk or the Dequinder Cut or visit, you know, um, Belle Isle and go for a bike ride in your neighborhood or just walk to the grocery store rather than driving. All those things have knock-on effects for our mental health. And so as I get to know my patient, I understand that there are barriers in accessing cognitive behavioral therapy. And so not everybody has the means to drive or has the means to afford that type of service. And
Yeah.
I understand that. But if we can get it done with medication alone, plus lifestyle changes, that's great. And we'll know that with those sequential visits and those sequential Beck's depression inventory scores. And if we can do it without, that's great. If not, there's a hard conversation to be had about raising the level of the medication or raising the doses or trying a different medication or insisting that they must go talk to a behavioral health person. And if at the end of 6 months or 9 months we're not making any progress, that's the time where we refer out to psychiatry.
That makes sense. And so, Bill, my colleague, Dr. Bloom, I know we work a lot in we sometimes we collaborate with pediatricians, right? We see a lot of kids sometimes for evaluations. Um, Any questions for you? So Dr. Paul Thomas was talking about how
Mhm.
direct primary care is really geared to improve access, help the patient get access to the clinician faster, more regularly at a typically at a price that's more for like can save them money in different ways. Um, what's been your experience? Do you ever in your work? I know you've been a neuropsychologist for many years. And have you had a chance to work with any kind of direct primary care physicians? Is that have you had any experience with that kind of care delivery model?
Yeah. Well, first of all, it's nice to meet you, Dr. Thomas.
Nice.
A large part of my career has been embedded in medical specialty services. I have worked alongside physicians other than psychiatrists. And it is the collaborative element of it is really helpful to patients. Being able to collaborate from both the medical side of things as well as the psychosocial parts of them is really, I think, looks at total care for patients and is really to their benefit. It is a reality that many times the physician is the first person to be able to detect depression. And it's a critical element. Everything you're saying, Dr. Thomas, is exactly, I've seen it in action and it's very effective. There are situations, bereavement situations. Sometimes there's psychosocial stresses, there's economic stresses these days that impact a person and can lead to depression. And that is where the collaborative approach is actually most helpful when there's a combination of biological and psychosocial stresses. And yeah, that's been my experience.
Yeah,
And then with the TBI patient population, because I've worked a lot with TBI patients, and depression is a very common coexisting condition with individuals with concussion or traumatic brain injuries.
sure. Um, Dr. Thomas, one of the things you mentioned was about access to care. Yeah, it's interesting. So Bill and I we actually have we have this new initiative that we're working on starting this fall where we have graduate level people who are completing their PhD or PsyD or masters in a mental health discipline like psychology or social work or counseling. We have now we have the option to they could see patients at a reduced rate like $20 $30 a session. So we have this new initiative where we actually try to connect with primary care offices around our region to say, yeah, we know that a lot of patients, some patients have sort of traditional commercial insurance like Blue Cross, Aetna, Priority Health. Some people don't, and so we're trying to. One of our kind of works in progress is to try to make some of those services available to people who need the help but may not have either the insurance or the financial resources to pay for therapy, for example. So that's I think that's often sometimes we'll get like many calls per day of people requesting services, but at least 20% of those calls are people who don't have, they might not have commercial insurance or they might not have financial resources. So we're trying to, we see that in our own setting. So we're trying to kind of respond to it in a way that hopefully offers the care that the patient needs at a much more affordable rate.
That's great. It's a needed service. One comment I'll make is that many psychiatry offices are located in the wealthiest communities, as you know. And
Sure.
so, as with primary care, there are too few primary care doctors in Detroit. There's probably a ratio of one primary care doctor to every 6,000 residents in the city of Detroit. And there's one primary care doctor for every 600 residents in Oakland County. So there's a 10x primary care disparity
Yeah.
across 8 Mile. And similar stats, if you go over to Ann Arbor, there's one primary care doctor for every 612 residents or 618 residents. I can't remember the exact
Sure,
ratio,
sure,
but
sure.
still a 10x disparity. So, you know, and oftentimes lower income folks bear a higher burden of mental health conditions due to that psychosocial stress, lower financial means, can be a burden in itself. So, I would love to live in a world where we can absolve, bridge some of these gaps in care and get more psychiatric resources in lower income communities and get more primary care resources in lower income communities as well. Um, because those are the communities that often need these services the most and they're often overlooked, sadly.
And is that part of the reason I know that one of your, maybe your main location or one of your offices is in Detroit, right? Was that kind of part of your motivation to be in the city?
Yeah, definitely intentional to address some of there's a federal designation, health professional shortage area, in
Hmm.
which we are located in our Detroit office, our Van Buren office, our Corona office, and our Lansing office. We do have a Royal Oak office, but that's more of to address, you know, the geographic needs of our patients. So some people live close to that office in Oakland County or even the northern end of Detroit. So um, we love being able to address that health disparity. I would also call on some of our corporate partners in the healthcare space. The largest healthcare provider in Michigan um, has some 60,000 employees, 300 outpatient facilities, and they have zero offices in the city of Detroit.
Yeah.
Uh, and then another of our healthcare partners, largest, one of the maybe second or third largest healthcare partner in Michigan, is building a $2.2 billion facility at West Grand Boulevard, but making no further investments in primary care in the community or psychiatric care in the community. But as we all know, more money invested in primary care. Primary care could be OBGYN or
Yeah.
pediatrics or family medicine or med peds or internal medicine or psychiatry, yields the greatest savings for the healthcare system overall. But we continue to fail our neighbors and the residents of Michigan by our continued disinvestment in these areas.
Thank you.
It's a challenging situation, frustrating, extremely frustrating to watch these developments in this space.
Right. I mean, I think the lack of access to kind of everyday healthcare needs, I think it's top of mind for most people. Like our healthcare expenses always go up every year, but that doesn't necessarily mean that our actual health outcomes or ability to access care or well-being is improving along with that, right? So our
Yeah.
costs go up, but our
Yeah, I'm looking at it this morning. A Milliman Medical Index. This was just published this week.
yeah,
Our healthcare costs are going up 7.8%. The average annual healthcare cost for a family of four, $37,824. That's just the insurance cost, the healthcare cost for a family, and an individual cost is $8,460. Sorry, the increase was 7.2% from 2025 to 2026.
Yeah.
Um, and we're not getting any healthier. Life expectancy is still below the average of many other developed nations, and our health span is worse as well. So we might live 77 years for men or 79 years for women in the United States, but our health span is only 66 years or 68 years for men and women, respectively. Um, and I believe that we're failing in this regard because we don't have enough investment in primary care. The United States invests 7% of our healthcare spending on primary care, and these other developed nations in Europe spend 14% or twice as much on primary care. So I think there's a long way to go. Primary care, of course, includes mental health, physical wealth, prevention, and all these things. But we need, as a nation, as a community, as corporations, as municipalities, as school districts, we need to invest more into primary care. Otherwise, we're going to continue to get these worsening health outcomes, lifespan outcomes, and health span outcomes that we are living with today.
and I know we only have a few more minutes, so I appreciate you making the time to be on the podcast. One other question I have for you is, what do you think about what's the role of learned or developed skills or behaviors, like in terms of how we, right? I mean, there's access to primary care and to a qualified clinician makes a lot of, it's very helpful. We all need to have access to that. But is there an additional role in terms of how do people learn to take care, how do people learn to be mindful of their health, take care of their health? I mean, you have to have time and money to be able to do that in the first place. So that's obviously part of the conversation, but what are your thoughts on sort of, I don't want to simplify it to say it's learned behavior, but kind of one's
Yeah.
ability or knowledge base about how to take care of oneself, how to make hopefully healthy decisions. How do you see that?
Yeah, I read a book recently called The Anxious Generation. If you haven't read it, I strongly recommend it. But it, I mean, whatever we're doing right now in our society, we should be doing the opposite, right? It's like the whole premise of the book is that we're our children are increasingly becoming depressed and anxious because of their access to cell phones and specifically smartphones with social media access. Um, because you know we shouldn't give children smartphones until they're 16 or 18 or 20, right? Because they need to form a sense of self that's well defined within the context of a community of real people and not of artificial beauty standards that are pushed on social media or even AI generated in images or AI enhanced or airbrushed images of models or you know people on TikTok or Instagram. So um, I would love to see a world where we have healthier mental health for our children, for adults, by limiting smartphone access to children until they're 16. I firmly believe that we should have smartphone lockers for kids when they enter the school. Like if you're going to give your child a cell phone, that's fine. That's a individual decision for you and your family. But all the phones should go into a locked bag at the start of the school day so children can learn um, without access to their cell phone. In Michigan, we're the 40th in reading rates for third graders across the nation. Um, we're statistically behind in reading and math, and we're like in the bottom 10 now. And I firmly believe that we need to take some um, stronger action to focus on education, and one of those actions should be limiting smartphone access because it has many negative knock-on effects for mental health for our kids and communities. Um, and we need to develop more third spaces where kids can gather and play
Sure.
uh, unsupervised as children and have agency and autonomy so that they can go out and be with their friends on their bikes and make safer places in our communities. Unfortunately, in Michigan, we've overbuilt our road infrastructure, and many people live in cul-de-sacs or communities that are not walkable. Um, there are many things I would love to do, but I'll leave you with the anxious generation. If you watch this podcast or listen to this podcast and you want to listen to a book or read a book that will change your perception on how we raise our kids, that's one I strongly recommend because it has significant impact on our mental health going forward.
Well,
Yeah, I would just
go
I appreciate you saying that, and I do want to say as a neuropsychologist, it's not only a issue of social and mental health development, but also our brains are being changed by these experiences, and not in healthy ways.
Yeah, we're losing our faculties of memory, um, and we're losing our ability to focus and concentrate. And
Mhm.
we're losing our social skills, which is
Yeah,
hard to watch.
absolutely. Yep. Yeah.
All right, on that note, I must go. You guys have a great day.
yeah,
And if you or your patients ever need an excellent family medicine doctor, or we have one internist on staff who can have the time and space to engage in whole person medical care, um, from young children to older adults. We take care of all people from all walks of life, from every income strata across Michigan. We love doing this work. and we can certainly address their mental health concerns as well. So thank you so much for letting me plug Plum Health.
Yeah, thanks. Good to talk with you, Dr. Thomas. Thank you for your time.
Thank you.
All right, take
Bye.
care.